Hello everyone. Today's my seminar is Auscultation. So it contains definition, parts of stethoscope, breath sounds, voice sounds and heart sounds. So first of all, definition. Auscultation is the process of listening and interpreting the sounds produced by air movements within airwaves and lungs with a stethoscope. Auscultation is a diagnostic procedure, first of all. Secondly, see now for explaining, I'm explaining this. Auscultation is the process of listening. So, auscultation is a procedure, and with the help of stethoscope, you can listen the voice and the airwaves and the movements of the movements in the chest and in the abdomen with the help of stethoscope. Now there are mainly three types of sounds which we can hear by the auscultation procedure. First is breath sound, second is voice sounds, and third is heart sounds. Now breath sounds include normal, abnormal and adventitious sounds. Voice sounds includes egophony and bronchophony. Now this all the types of sounds suggest some or other pathology which helps in diagnosis of some or other pathology. So first of all, the parts of stethoscope: uh, ear tips, binaural, spring, then the latex free tubing, then the chest piece includes the diaphragm, non-chilling ring and the drum. Thus, these are the parts of the stethoscope. Now, first of all, breath sounds. Breath sounds are divided into three types: bronchial, bronchiovesicular and vesicular. Now, characteristics of breath sounds. There are mainly four characteristics: pitch of the breath sounds, amplitude or intensity, distinctive characteristics are listened, and duration of inspiratory sound compared to expiration. Now, pitch in terms of vibration frequency and amplitude or intensity, that is in terms of loudness. Now, those are the main pathways of the air through which we can hear the characteristics and the abnormal breath sounds, that is trachea, pleura, diaphragm, mediastinum, lung and bronchi. Now first of all, first type of the breath sound, that is bronchial sounds. Those sounds are loud, high pitched, hollow quality, heard over manubrium, louder on expiration, distinct pause between inspiration and expiration. So you can interpret this thing from this graph mentioned here, that is, this is inspiration and this is expiration, and the pause is mentioned over here in the graph. So bronchial sounds are loud, high pitched and hollow in quality, heard over manubrium, louder on expiration and distinct pause between inspiration and expiration. Now bronchiovesicular sounds, mixture of bronchial and vesicular sounds. Both of these sounds are 1:1. Those sounds are heard over main stem bronchi and on anteriorly. The ratio of inspiration and expiration is 1:2, and it is seen over here in the graph. The vesicular sounds, soft, low pitched sound heard over peripheral lung tissue. No pause between inspiration and expiration is found, and the ratio of inspiration is to expiration is 3:1. You can see in the graph mentioned the inspiration and the expiration part goes like this. Now abnormal breath sounds. Abnormal breath sounds can be described as when the sound transmission changes as a result of underlying pathologic processes. There are three types: bronchial, decreased, and absent. Abnormal sounds and the characteristics are mentioned in the table. Bronchial sounds, that is, occur in the peripheral lung tissue. Decreased sound, that is, sound transmission is diminished or abolished. And absent sounds, when no sounds are audible. So those are the three types of abnormal breath sounds. Now adventitious breath sounds. Adventitious breath sounds are the extraneous noises produced over the bronchopulmonary tree and are in indication of abnormal process or condition. There are three types, that is wheezes, crackles and rhonchi. Here is the table showing all the characteristics and the pathology which are related to it. So first of all is crackles. Characteristic is discontinuous low pitched sound, occurs when predominantly during inspiration. The sound is similar to paper between fingers and indicates a peripheral airway process or any pathology in a peripheral airway. Rhonchi, low pitched but continuous sound. It occurs in inspiration and expiration. You can hear both in inspiration and expiration. It is similar to snoring. It indicates an obstructive process in the larger and more central airways. The crackles suggest peripheral and the rhonchi suggest central. Wheezes, continuous but high pitched. Rhonchi is low pitched but continuous. And crackles are discontinuous but low pitched. The occurs when predominantly during expiration. Wheezes are similar to whistling and it indicates bronchospasm, that is asthma. Now pleural friction rub, that is cracking or grating type of sound. Inflammation roughens the surface of visceral and the parietal pleura, similar to walking on fresh snow or on the dried leaf. Inflamed pleural air layers and loss of lubrication. So those are the adventitious sounds. Now voice sounds. They are vibrations produced by the speaking voices and it travels down the tracheobronchial tree and through the lung parenchyma when heard with a stethoscope. They are low pitched in normal lung. There are three types: bronchophony, egophony and whispering pectoraloquially. Voice sounds. Bronchophony, that is increased vocal transmission. The characteristics is words or letters are louder and clear. An increased lung density can cause bronchophony or it suggests the bronchophony. Example is consolidation of pneumonia. Patient is usually asked to repeat 1, 2, 3, 4, 5, 6 like that numbers and you can see increase in vocal transmission. Now egophony, that is increased transmission of vibration. See, this is the difference. Bronchophony is increased vocal transmission and egophony is increased transmission of vibration. Now this is heard over peripheral area and bronchophony is heard over the central area mainly. Egophony coexists with bronchophagny. Patient is asked to say E. The underlying process distorts the E sound so that an A. So this is the difference between egophony and bronchophony. The whispering pectorally is a smaller patchy area of consolidation. Muffled low pitch sound is heard and high frequency of vibration is also there. Now heart sounds. As with lung sounds, superficial topographical landmarks assist the therapist in auscultation of heart sounds and murmurs. Normal heart sounds are S1 and S2. Abnormal heart sounds are S3 and S4. Now the table shows the S1, S2, S3 and S4 and the characteristics. S1 sound is the sound of the closing of AV valves. The time duration is 0.1 second or 0.10 seconds, and the sound is like lub. The S2 sound is the closing of the semilunar valves and the end of ventricular systole. It lasts for less than 30 milliseconds and it is dub in the sound. The S3 reflects the early diastolic ventricular filling that occurs after the atrioventricular valves. The time is not clearly mentioned, but it is dull in sound. And S4 is the rapid ventricular filling that occurs after the atrial contraction. When present, it is heard before S1 and the sound is dull. Cardiac murmurs. Cardiac murmurs are the vibration resulting from turbulent flow or the turbulent blood flow. These may be described based on position in cardiac cycle, systole or the diastole, duration or the loudness. Systolic murmurs occur between S1 and S2. Diastolic murmurs occurs between S2 and S1. A continuous murmur starts in S1 and lasts through S2 for a portion or all of diastole. Murmurs that are grade 3 or greater are usually associated with cardiovascular pathology. So now see this systolic murmurs and diastolic murmurs. See, S3 is diastolic murmur, so you can hear that sound between S2 and S1. And the S4 is the systolic murmur, which you can hear between S1 and S2. So this is the difference between systolic and diastolic murmur. Now grades of murmur. The grade 1 is faint and requires concentrated effort to hear. Grade 2 of murmur is faint and audible immediately. Grade 3 is louder than 2, intermediate intensity. Grade 4 is loud intermediate intensity associated with palpable vibration and a thrill-like sound is found. Grade 5 is very loud thrill present and grade 6 is very loud thrill present. So there is merely difference between grade 5 and grade 6, but the loudness differs between grade 5 and grade 6. So thus this is the theoretical part of the auscultation, and the reference is cardiorespiratory physiotherapy, adults and pediatrics, Barbara Weber, Jennifer Pryor, Amini Prasad, First Southeast Asia edition. Thank you.